So I have my assistant,
Okay.
Ferris, who's going to be, involved in helping us with the logistics of the audiovisual recording. And Ferris is actually doing his master's in neurosciences and
Okay.
also helps me with everything. Yeah, and sorry, completed it.
Completed.
And
Okay.
also, I have Dr. Azim Sheikh, who has been my partner for many years, and we have been working together with our own research. And I wanted to also introduce you, Dr. Enas, to him as well.
Sure.
Hi, Dr. Enas. Pleasure to meet you.
Yep.
Nice meeting you.
And once again, we thank you so much for being available for this. And I wanted to just start out with introducing you to our audience here. And so I want to mention that you are a true pioneer. You were the first cardiologist who basically brought up the whole issue about the striking problem with amongst South Asians regarding heart disease, not only in of course South Asia, but also especially amongst the immigrant community or the diaspora, amongst the people who have migrated to the West. And you basically described it as an epidemic, and how you were able to scientifically prove through your study, particularly the CADI study, that there's a 3 to 4-fold increase of coronary artery disease amongst immigrants from South Asia to the United States. And you also were the first to talk about, lipoprotein small a as a genetic variant that was very prevalent among South Asians. And I know you've dedicated your life to this whole cause, and you've received many honors. In particular, you have, of course, presented numerous presentations and given lots of lectures, invited lectures, but you've also received numerous awards and recognitions. Most recently, you had gotten, API had given you a Lifetime Achievement Medal. And I know you've given over 1,000 lectures, and we're just so pleased to be able to have you on this program. And I think we'll start out with our first question. Can you tell us about the statistics regarding heart disease in South Asians?
Getting the screen.
We just had the screen on. Yeah, the video wasn't on, but can you see the slides?
No, you have to go to full screen.
You did full screen it?
Yeah. Just getting some logistics.
Oh, maybe share.
Okay, share the screen.
Yeah. This one.
Okay. Let me get this. Okay. Thank you for inviting me, and I'm happy to share the latest information, which also will be coming in my upcoming book. These slides are not published. It's compiled from Institute of Health Metrics. South Asians account for 24% of the world's population, and they account for 20% of all death and at all ages. But that increases to 34% when you consider the death rate only in the age group 50 to 69. And what is most striking is that death rate from 20% goes up to 38%. So wow. South Asians account for 50% of the CAD or heart disease death under the age of 50. If you take India, that has been my focus mostly, they account for 30% of the death under the age of 50, whereas they account for only 18% of the world population. And Pakistan and Bangladesh follow the same pattern. In this study, Institute of Health Metrics study, it showed only a lower rate, 2%. But the other studies, including the just published study from the pure study shows that Pakistanis in general has double the rate of heart disease than Indians, and Bangladeshis have actually 4 times more. That is the data from South
Wow.
Asia, as well as coming from the UK. Then China, 18% of the population and only 14% of the premature CAD. And overall, the rate is 8.4. So here we can see that Indians or South Asians problem is not heart disease, but heart disease at a young age, which I have characterized as malignant heart disease.
Yes.
Now, let me take to the next slide. This is even more striking. Usually, women do not get heart disease until after the age of 50 or menopause. But in this study, showing that Indian men account for 36 or 37% of death under the age of 50, whereas 41% of all female death are in South Asians.
Wow.
Overall rate is 9% for men and 4.5% in women. Okay.
Okay. Wow. That's very alarming. Can you explain how heart disease is different in South Asians?
Okay. I have described 5 characteristic features. Extreme prematurity, I already showed you. Extreme severity, I'm going to show you. Rapid progression of the disease, I'm going to show you. High death rate at young ages, I already show you. And the 5th one, established risk factors like smoking, blood pressure, cholesterol, and diabetes do not explain this heightened risk, particularly at a young age. And this question has been asked even by New York Times. Why do South Asians have such high rate of heart disease? I was glad to see that article because when I first started talking about this, nobody believed. People thought I was crazy by saying this, how the Indian population or South Asians are vegetarians and how come they should have such heart disease? Now, the latest and most compelling data came from UK, what is called UK Biobank study, 11-year follow-up of nearly 500,000 people, including substantial number of South Asians. What they found is that they have doubled the incidence of ASCVD, which includes both heart attack and stroke. But using the pooled cohort equation that's used in the US and QRS3 used in UK, failed to identify any higher risk at all.
Wow, that's amazing.
I have been saying this for the last 20, 30 years, established risk factors do not explain, but now we have the official proof from that.
So basically what you're saying is that there's obviously a much higher rate, like double, but the risk factors that are supposed to predict it is not seen in South Asians.
That's correct.
So it is a uniquely, unusually different version of compared to what's seen in Caucasians of European origin.
Yes.
Okay. Can you explain how the risk factors for heart disease then are different in South Asians? Are there some ways to identify the risks in South Asians then that are,
yes,
even though it's different?
Actually, so far as I am concerned, there is no mystery for that. I will go through that down the road. Let me go through the risk factors. The major risk factors and not so major. And high cholesterol is foremost risk factor for heart disease, 50%. High blood pressure is the second foremost. Tobacco use, diabetes. First 3 are similar or lower among South Asians. Diabetes, 3 to 4 times more. I have more slides to show. Physical inactivity, Indians exercise their brain, but not their body. So physical inactivity is much more common. High triglyceride is much more common. That probably is related to high carbohydrate diet. Then there is what's called metabolic syndrome, high BMI and waist girth based on the South Asian criteria. Now, the new information coming out very, very strongly is low education is a very important risk factor. Air pollution has now actually overtaken smoking in South Asia, and lipoprotein is a non-modifiable risk factor, along with the South Asian ethnicity, age and gender, family history, polygenic risk score. But lipoprotein is on the verge of becoming a modifiable risk factor.
All right. Well, the other thing I'd like to know is some of the specific discoveries that you have made regarding South Asians and heart disease.
I'll be happy to. Actually, as you already alluded to, I am the first person to address this issue. And I made, from 1970 onwards, when I was a first-year resident, made personal observations on extremely premature heart disease among my colleagues, basically first and second-year residents. They were here in the US only 1 or 2 years. Then
and they were getting affected.
Yes.
Wow.
And I alerted the world about the heightened risk of heart disease initially based on my observations alone. Then I conducted the CADI study, which confirmed, yes, I was not imagining, it really does happen. Then we came across lipoprotein little a, and the genetic studies show that lipoprotein little a increased the risk by 2 to 4-fold. I am the one who report first lipoprotein little a among Indians. Then at that time, we found 25%, that is 1 in 4 South Asians. My studies are all in Indians because I don't have access to other South Asians, but Indians, they have 25%. And 2 years ago, the National Heart Lung Blood Institute reported that yes, 25% of Indians have high levels of LPA-little a, confirming our observation. And in 2018-20, both South Asian ethnicity and lipoprotein little a were incorporated into the guidelines. And those who have the risk enhancing factors, they qualify for statin therapy if the LDL is more than 70. Let me show you a couple of the cases. Massive MI, 2 Indians aged 25 and 26, fellow residents. 2 Indians, 37 and 39. And 39, with the first MI, found to have inoperable heart disease, died in 5 Indians. The second patient I am going to show again, this 37-year-old guy. And 2 Indians by 45 and 47, he had a bypass surgery. These are also doctors. Bypass surgery at age 44 and MI, massive MI at age 45. Now, when I saw the person made the observations, I had no access to the data coming in from UK. Professor Littler noticed, and this is very prescient, he just wrote a single half-page report that he found 4 Indians with MI between the ages of 18 and 20. He could not find anybody like that in the entire UK. At about the same time, or about 5 years later, Balarajan reported on the mortality rates among Indians compared with the standardized mortality rates in the UK and found exactly what I was saying. 2 times higher death rate at ages 30 to 39. And look at here.
Wow.
3 times higher death rate at Indians aged 30 to 39. Let me show you now this slide. Practically all my lectures, I show this one. This is the slide disproving one fact, or that I will come to that. This is a person who had MI out of the blue. He was the chief of psychiatry at Cook County Hospital, my alma mater. You can see that humongous coronary arteries.
Yeah.
You can drive your truck to the arteries. Now, 10 years later, this is his angiogram. Nobody would believe this angiogram and that angiogram belong to the same person. Here he has
Oh.
got a left narrowing left main, and his LAD was completely gone, circ was completely gone, and some of the small arteries got enlarged, but because of the collateral formation. So Indians do not have small coronary arteries, but by
That's
the
so
time,
interesting.
but the time you do the angiogram, anyone who sees only this angiogram will undoubtedly will say, oh, Indians have small coronary arteries.
Yeah,
So,
yeah,
but if you look at this angiogram, most people don't see the first one. You see only the,
yeah.
okay.
That's really fascinating. So
Yes.
it's actually, it is truly a myth because, I'm seeing this even propagated with recent articles
Yes.
that people are saying, no, they definitely have it. They definitely have it. But I think they're not looking at the baseline like
Yes,
you are.
okay. And so I heard this, and I have seen this phenomenon. So actually, this is the case I used to describe malignant heart disease in young Indians. In 10 years' time, his year went from 65 to 25%. There is no blood going through any place. So I wrote the malignant heart disease and used the limited information to link this malignant heart disease to lipoprotein little a. So we covered some of the issues earlier. So I had the opportunity to alert the world about the heightened risk of heart disease and prove Indians in the US have 3 to 4-fold higher rate of heart disease. So that we'll show you soon that Indian vegetarians do not enjoy the cardiac protection enjoyed by the Western vegetarians.
That's really interesting.
We reported that established risk factors are extremely important, but they do not explain our problem. Report 1 in 4 Indians have high Lp(a) and coined the term malignant heart disease in young Indians and link it to lipoprotein little. And now new information, and that is describe that CAD is worse in India than in the Indian diaspora. When I was talking this, people beginning to accept this thought that, oh, this was all you abandoned Mother India and came to another country. Okay, this is the penalty you are paying, or for the stress of immigration. And now disprove the widely held belief that Indians have small coronary arteries. This is my very first article in the RP journal. And I was the treasurer. I was groomed to become the president. I decided not to move up the ladder and do the CAD study on the Indian doctors. So I said, immigrant Indian males sitting ducks for heart attacks, a cause for alarm and call for action, because I had no information about the people in India. Then came this plaque. This is the plaque removed from the right coronary artery of a vegetarian with a picture-perfect lifestyle, and he was a pathology professor with a picture-perfect lifestyle. This was the plaque removed from the completely occluded coronary artery, but his problem was much worse than this. Here, left main here, 75%, LAD 99, multiple stenosis here, and right was completely occluded. And by the time he was in the United States only 7 days. That plaque did not start developing in 7 days. So it was in the making for 20, 30 years. So when I wrote most of my papers are invited papers now. So when I wrote the second paper for India, I said coronary artery disease epidemic in Indians, a cause for alarm and call for action. I already alluded to the high risk in women, and now we are seeing that both women and people in India have the same heightened risk. Now, the vegetarian paradox. We use the Framingham offspring study as the comparison. You see that vegetarians and non-vegetarians are no difference in heart disease rates. Rates were similar to New Delhi and Chennai, but Kerala and Goa had higher rates. These are 2 states with the highest consumption of coconut. Okay.
Wow. That's so there is a connection with coconut oil, you think, and heart disease also.
Yes. Coconut oil and all coconut products.
Wow. Okay. Can you also, while we're on the topic, describe what you mean by malignant coronary artery disease?
Malignant heart disease is the one I described earlier. Okay, heart disease. I have actually described the heart disease among Indians into 3 different types. One is type 1 heart disease happening under the age of 50 without the established risk factors. And that is like a type 1 diabetes. Then there's a type 2, just like anybody else, like a type 2 diabetes. There are all kinds of risk factors. Type 2 heart disease is very similar to all other populations. They have plenty of established risk factors. Type 3 diabetes, we have only type 1 and 2. I have something in between. So the type 1 is under the age of 45, under the age of 50. Type 2 is above the age of 70. Type 3 is between ages 50 and 70. They have some risk factors and some elevation of lipoprotein little less. So malignant heart disease is like the type 1 disease happening without, or type 3 with or without established risk factors.
Oh, wow. Okay. So I wanted to also ask you about the connection in South Asians between coronary artery disease and diabetes.
Thank you. So that is another fascinating data. Diabetes is unquestionably an important risk factor in Indians, and I have some slide later on showing that one. And it's associated with a 2 to 4-fold. It used to be considered a CAD risk equivalent, is no longer. Now, I'm going to show you some provocative data. This is relative risk of diabetes for Indian Americans and Asian Americans, with the white as the standard, adjusted for age, sex, BMI, education, income, smoking, alcohol use, physical inactivity, everything adjusted for. Indians have 3-fold higher risk of diabetes, whereas others, Chinese, or other Asians, all Asians have only slightly increased. Filipinos have 1.6, whereas Indians have 2.8. Now, another data. I'm sure you are familiar with the MESA and Masala studies.
Yep.
MESA study, this is data from MESA. Asian Indians, 26% prevalence and 25% pre-diabetes. Whites, 7% diabetes, 25% pre-diabetes. And even the blacks and Hispanics, well known for the high rates of diabetes, they have only less than 20%. But Indians have the highest risk.
Wow. Our South Asians also
have, okay, go ahead.
Oh, sorry, didn't mean to interrupt you there.
Yeah.
Please continue.
No, I was going to look and talk about the stroke.
Yeah. So yeah, talk about the higher risk. Are they at higher risk for strokes as well?
No, this is an important factor. Usually, most of the lectures on cardiovascular diseases, but for Indians, among the Chinese and Asians, stroke accounts for more incidents and more death. For every heart attack, Chinese used to have 4 stroke. Same thing for Japanese. But South Asians have, even though they are Asians, they follow the Caucasian pattern. They have 3 to 4 times more heart disease than stroke. So yes, South Asians have similar or lower risk of stroke, hypertension, heart disease, and peripheral arterial disease, even though the risk factors are similar. South Asians also have lower rate of cancer, about 1/2 to 1/3. So there is something good because of that. The overall death rate from heart disease, death rate from all causes are not higher in Indians than other populations. And no country has increased life insurance rate for Indians, because this was the most challenge I faced when I started talking about the heart disease. Fellow cardiologists and fellow doctors and non-doctors were saying that, oh, you are doing a great disservice to our community. They were worried about not dropping dead, but about life insurance premium going up. It has not happened because life insurance does not look for the cause-specific death rate. They look only for the overall death rate.
Okay. Let's go to a different topic then. How about cholesterol? How does that factor in for South Asians? How is there a different pattern for cholesterol?
Yes. Cholesterol, this is again Cardi study. This actually is funded by my research foundation and with a $25,000 seed money from API.
Mm-hmm.
And we looked at with this Framingham heart study. So to see the standard for the American population or white population. And this is doctors and cardiologists who know the risk and risk factors to begin with. Smoking, 10 times lower.
Wow.
Obesity, 10 times lower. Blood pressure, cholesterol, LDL, HDL, triglycerides were similar, which means statistically not different. They were statistically similar, even though slightly elevated. Diabetes was 9% then, now it is 18 or 26%. So diabetes was the only thing we found. But this gives the impression that cholesterol is not a factor. That's not correct. Mm-hmm. But we compared with the whites, but new data coming up, becoming cholesterol is truly a problem. See, these studies were done at that time when LDL 160 was considered normal. Okay, then this study was done called Cardia study and measured the LDL, cholesterol and LDL, and 20 years later, they did the calcium score. And they found that LDL 160 had 4 times more calcium score than LDL 70. So LDL 70 was associated with the least risk at that time. But now, actually, even 70 may be high, LDL 40 or 50 may be more optimal. In fact, the GBD, Global Burden of Disease Study, defines the optimum level of LDL as 27 to 50. So yes, we have a problem, but not higher than that of the white population.
Huh. And now let's talk about lipoprotein A. This is something that you've really brought full attention to, especially in South Asians.
Yes. Actually,
you were the first to call the alarm on this.
Yes. And it's a very interesting story. When I wanted to do the research, I'm in the private practice. I am not an affiliate with any university. So doing a national research is next to impossible.
Yeah.
So I went to NIH and my friend Salim Yusuf was there.
Oh, yeah. Wow.
Yeah. He invited me to come to the NIH and that's also a special day. Saddam Hussein invaded Kuwait and I invaded his home and stayed there for 3 days when the war was going on. Okay. And then he introduced me to the NIH chief and also a gentleman by name Thomas Pearson. And he is a consultant to NIH. And NIH chief told me that, yes, there was one report of high rate of heart disease among Indians from Singapore, which nobody has heard or known, even though it was in the Indian Heart Journal. No, American Heart Journal. So Thomas Pearson and Salim are friends with him, and we went for brainstorming for lunch. Then he told me that, Enas, you should look into LP. I said, what is the normal? How do I measure it? Because there's no standardized measurement. So how do I make sense out of it? He said, okay, I have an easy solution for you. What is that? I am following 1,000 white doctors and from Johns Hopkins and 500 black doctors from Mehari Medical School. And we can plug in your number and I will do it. You just send me the sample and they will charge me only the cost of the testing. So I did he said that you should test lipoprotein little. And lo and behold, I tested and found that 25% of the Indians have high LP little a, and that's how I first published. Now, lipoprotein little a is the most dangerous LDL there is. It's a genetic variant. This is of the LDL, to which is attached an ApoA, which has 40 different isoforms. Small isoform is more dangerous and large isoform is not very dangerous. And this LPA makes LPA much more dangerous than LDL. Another thing is that LPA, unlike other risk factors, LPA level is determined at the time of conception and affecting 10 to 30% of the global population, 10 to 30%, and leads to CAD, MI, stroke, and heart failure. Now, this is aortic stenosis. Up until LPA, there was no identifiable cause for aortic stenosis. That is now the only cause identified. And it produced blood clot without even plaque rupture and produced MI. And in addition, produced stroke, chronic kidney disease, heart failure, peripheral arterial disease, and stroke.
Wow. Can you also talk about, I know you've talked a lot about LPA. Can you tell us about how it relates to South Asians? And also, you know, some of the studies I thought mentioned that it was as high as 44% in South Asians.
Yes, that is, see, even now, there is no agreement on what is the cut point for lipoprotein little a. Studies have shown, especially in the fresh plasma, and studies in India has shown that LPL becomes a major risk factor, LPL level at 20. Berkeley used to have one of the standard measurement of LPL. At that time, they used the cut point as 20. So I teamed up with Superco and measured LPL. At that time, they used that was their upper limit of the normal. So we found LPL more than 20 was found in 44%. When I used 30 was the cut point used. Now there's a debate going on that it should be 20, 30, and I have a feeling that the first threshold to be decided might be even 70, because there's an outcome trial going on in people with LPL more than 70, and the outcome studies shows it the benefit of lowering it will be limited to people with the 70. And don't forget, when cholesterol was, when I was a cardiology fellow, cholesterol was 330 was normal. And I started off with 320 cholesterol. And I was told by my professor, don't worry, 320 was normal. So these levels are being, the cut points are being developed. Now, pursuing on that question, okay, lipoprotein level 30, most people agree 30 is the cut point. But, and it was the cut point in the US also. But European guidelines used the 50. Then there was a conflict, US guideline 30, European guidelines. So US guideline now says 30 to 50, they say. So this is looking at the rate. If you use LPL 30, 35% of the population have LPL, and look at this number. 2.45 billion people, B with a billion, 20%, 1.4 billion. So it depends upon what is the cut point, which is to be determined. Now, this is data about relevant to Indian South Asian population. White, there are two units for measuring or expressing the elevator levels. This study used, and this is perhaps more preferable unit, is nanomoles per liter. Okay, 90 nanomoles for white, in South Asians 31, which means lipoprotein little a is 60% higher on a population level. Now, this is not using any cut point, just a median level. And Chinese, Indians have doubled. Blacks have higher LPL, but newer studies are showing that blacks somehow are protected and it's not harmful. Now, this is a study I was referring to. So the diabetes is an important risk factor in the Interheart study by Salim. diabetes, the prevalence was 10%, and odds ratio was 2.52, and population attributable risk was 12%. LPA was neck and neck with diabetes,
Oh, wow.
10%, and the odds ratio were similar. But in this study, only 9% had high LPA. So we don't quite understand, but most of the studies are done on specimens stored for 10, 15, 20 years. There are some studies showing that when you store the specimen, the small isoforms, which are more unstable, they selectively decrease. So I do not know, but I want to put in perspective.
And this was in South Asians, of course, right?
That's right.
All of this data. Okay.
Yes. Global number 1.43 million people have LPA. Globally, diabetes 415. So at least 3 times more common. Everybody knows and worried about diabetes. 3 times more common. Now let's look at South Asians. 100 million South Asians have diabetes. This is from the NHLBI report. 469 million, this NHLBI estimation. Nobody has measured LPA on all South Asians. Now, Indians, 71 million diabetes, 321. Prevalence diabetes, 3 to 10%. LPA globally, 10 to 30%. South Asians, LPA 50 milligram, 25%, diabetes 78%. And we already discussed, if you use the cut point 20, 44%. The risk is identical. LPA 2 to 4-fold risk, diabetes. So it clearly shows it is at least as bad as diabetes, and perhaps 2 to 3 times more common and therefore more dangerous.
Wow. Impressive.
Let me give you, since I told you all the bad news, let me share with you at least one good news.
Okay.
Everybody has low HDL and everybody worry about the HDL. So HDL is gone with the century because low HDL and high HDL both have increased risk of heart disease and all-cause death. And genetic studies show that genetically elevated HDL, particularly above the age of 80, somebody had HDL 100, we used to compliment them. Oh, no longer. So you can stop worrying about the HDL, stop worrying about the HDL and worry that too, or the LPA. Shift the worry to LPA.
So there's actually, the focus should be on LPA small a, and we should just shoot for an optimum range of HDL. It's not, it's really the bottom at the U curve where it's kind of somewhere between 39 and 60-ish or so.
And all the world over, all the guideline makers said that HDL is no longer a target of treatment. It's a reflection of the bad things happening, but not, it's a causally, and it used to be a negative risk factor, but nobody talks about it as a negative risk factor. So before I finish, okay, I want to show you that I have written 3 papers. Anybody, and I send you this one.
Okay. Yep.
This is the most comprehensive and practical review on lipoprotein(a), an independent genetic and causal factor for cardiovascular disease and acute myocardial infarction in all populations.
Wow.
Second one, ethnic differences in heart disease in 7 ethnic groups, done with Salim Yusuf. Third one, this is a must read for all Indians. And this is lipoprotein(a), an under-recognized genetic risk factor for malignant coronary artery disease in young Indians. Yep.
Familiar with this paper?
Yes. And now I am very pleased to note that the CADI research findings of LPA and South Asian ethnicity is endorsed and incorporated in the American cholesterol treatment guidelines.
Wow.
And they also said that if you have one of the risk enhancing factors like this, you qualify for statin therapy if your LDL is more than 70.
Amazing, impressive. All right. I have another question. Can you talk about some of the specific dietary recommendations for South Asians?
Yes, we are kind of going to open a can of worms, but okay. we're going to try that. Okay, I want to give some general principles and then specific guidelines. About more than 20 years ago, the Indian Heart Journal editor requested me, can you write a paper on diet? And we are hearing all this palm oil and coconut oil and meat and all these things. So where exactly in India, you have 100 different experts giving 101 expert opinions every day. So how do we make sense of them? So I said, okay, I can do that. Give me 6 months time. So I spent some time. Then since then, I have written several papers. This is actually very important, simple information. We have to appreciate there are healthy food and unhealthy food. Unhealthy foods are whole grains. Rice is whole grain, not all grains, most of the rice is refined grain. Fruits and vegetables healthy. Unprocessed lean meats are healthy.
So let me just make sure, you said whole grains are healthy, right?
Yes.
That's what I think. Okay, I think I might have misheard it earlier. Yeah. Okay.
Fruits and vegetables. Unprocessed lean meats are healthy. Legumes, particularly for the vegetarians, you need double or triple dose of legumes for their proteins. Nuts, seeds, and soy protein. No matter what, vegetarian, non-vegetarian, you need these things. Fish, especially oily fish. Healthy cooking oils, more healthy cooking oils you use, the better it is. Now there are unhealthy foods, fried food, and it's a proxy for trans fat. Indian food, Indians consume fried food for the breakfast, lunch, dinner, at home, and away from home. Refined, low quality carbohydrate and added sugar. Processed meats and prime meats, frozen and other pizza. Most of the fast food, egg yolk and bacon, foods prepared or eaten with butter, ghee, vanaspati, coconut and palm oil. So these are the things. I am not saying that don't use that sort of message. Use this sparingly or limit and use the other one. Now, what is our Indian food? Okay, you can
yes,
see.
I'm familiar with this. Yeah.
Okay, so this is consumed, not only consumed. You can see all the politicians, their their birthdays. It's not just a slice. It's a very sweets is part of the Indian culture. And what are they? These are refined grains with butter, with the sugar, and fried in oil, then put in some syrup. Okay, and this is consumed not sparingly, large quantities. Now, can you tell me what is in these dishes? These vegetarian dishes. This is how, okay, and they may be eating only naan. So all the foods, and I don't know which coconut oil or palm oil they are used. So we use a lot of refined grains and a lot of curries. Now, so I described what is contaminated vegetarianism. When compared with the omnivorous, Western vegetarians consume a diet rich in calories, saturated fat, trans fat, and sodium, but high in healthful, ingredients. We already mentioned that one. Western vegetarians have a lower level of systolic blood pressure, cholesterol, blood sugar, obesity, diabetes, leading to lower death rate, but not Indians. The point I want to make is that the Western vegetarian protection is not because they are not eating the meat, but they consume all the healthful ingredients, whole grains, legumes, fruits, vegetables, nuts, seeds, and fiber. 50% of the Indians are lifelong vegetarians, and another 40% are predominant vegetarians. When you go to the next buffet, Indian buffet, all the foods are similar, except non-vegetarians eat 1 or 2 pieces of chicken. Otherwise, 95% of the food is shared food. And you will never see any of the food I am going to show you. Okay, this is South Asians, especially vegetarians, have a form of contaminated vegetarianism. So they should follow 1 of the 3 diets. And I am a big fan of the dietary guidelines for American. This is the highest level of scientific evidence. This, there may be a little tainted because the dietary guidelines have to, the agriculture department and labor department have to agree on the dietary guidelines, but dietary guidelines advisory committee give detailed guidelines. They have come up with 3 diets: healthy American diet, the standard American diet; healthy vegetarian diet, this is what Indians should consume; healthy Mediterranean diet. Okay, now what are the bad food? This is the worst meat you can consume, sausages.
Yep.
There's nothing wrong in eating one lean steak once or twice a week or month. Now, the portion size is protein, vegetables and grains should be 30% of the plate. Fruits and protein should be 20%. Now, this is a typical healthy plate. There's a fruits and vegetables, there is a beans, there's a piece of chicken, there's a small rice. And showing the same thing. But if it's an Indian rice, this is going to be mostly 75% rice. Now, and this is what I eat, different combination of vegetables. Vegetables, Indians do not eat vegetables. They overcook and destroy every nutrient by cooking for 2 hours and making into sambar and whatever it is. Yep. So if you eat this, there are 4 or 5 different vegetables. This is packed with the nutrients. Indians do not pay attention, or they were not taught. I don't know. I'm not blaming them. So these things are available at least when you are here. Okay. So you should red grains, beans, nuts, fresh vegetables, extra virgin olive oil, nuts. There's no better food than nuts. All the minerals. And you have the groundnut, we have the almond, you have pistachio and coconut. So these are powerhouse. And one way to use the nuts is put it in your salad. If you put some nuts and put some extra virgin olive oil, some extra amount, this is as if you are taking some one breast of chicken, because this provides the fat and protein. This is good. This is good. Okay. But there's a problem in India with the contamination and poisons, but I am not going to talk about. We are in India, or here we can get different fruits. Okay. And also this vegetables. Okay. Now, okay. So what I would recommend, okay, I think that I have that here. So what can be,
great. Next question is, what lifestyle changes can South Asians make to improve their chance of not developing heart disease?
Yeah, and I have been thinking about for the last 10 years. Okay, and let me put this in perspective. So all South Asians should follow life symbol, because there should be life symbol for Indians throughout childhood, adolescence, adulthood, or entire life cycle. And why is that? And I want to give some background of this. Coronary artery disease. We told you that for South Asians, other disease, stroke, hypertension, peripheral artery disease, they are not players. It is coronary artery disease. But cardiovascular disease from 1969 to 2019, this is the latest data you can get, came down by 70, no, I cannot say came down, brought down by 77% in the last 60 years.
Wow,
now,
that is impressive.
Finland, 84%, US, 70%, 50 other countries have brought it down by 50%. The point I make is that the knowledge exists, the technology exists, the medications exist, the lifestyle factors exist to bring it down. But how do we communicate this, and when do we start? That is the issue. For that, okay, let me show you this one. Other countries. Look, Finland had the highest death rate, higher than. This country had the most exercise, and they brought it down by 84. UK, I already showed you. US. So this is not limited to Finland or US. This is the pattern. Okay, now, how do we communicate all this information into practical bite-sized steps? Bite-sized. That's called Life Symbol 7. It's just been updated to Optimal 8. Okay, Smoking cessation. If you're a smoker, if you're not a smoker, don't start. Eat better, we already covered. Lose weight, okay, we'll cover the weight a little more. Control cholesterol, we touch upon that. Get active and manage blood pressure. But now it looks very simple. But when you get to the nitty-gritty, the devil is in the details. Now, the American Heart Association championed the prevention. If there is one organization responsible for the dramatic 70% reduction in the heart attack and stroke, is American Heart Association.
Mm-hmm.
In 2010, they came up with the life symbol 7. And what are they? So this can be started and measured starting in first grade, age 6. Not smoking or do not smoke. Very easy to teach them and emphasize. Exercise, 150 minutes a week. Indians need, I modified it and published. Indians need double the exercise, but Indians don't get even 75 minutes now.
Wow, that's the irony of it.
Yeah, exactly. That's the irony of it. Okay. Healthy diet, we already covered. Okay. But we told you that there are so many.
And of course, this applies to South Asians as well. I mean,
Exactly.
all South
No, but I have no authority to speak for South Asian. Everything I am saying is applicable to all South Asians because of my recommendation. Exactly, all applicable. BMI is 23 as opposed to 25 for South whites, but we have a bigger problem. I have more slide. Okay. Waist circumferences of 1 or 2 centimeter is acceptable for Americans, but it's 12 centimeter longer for Indian men and 8 centimeter. If we get this and 100%, or no, I cannot say 100, 98% of the children have optimal waist and BMI in the grade school and school. So we have to educate these numbers and advise them to keep it. There's another simple formula, and that is keep your waistline less than half your height.
Yeah.
Less than, okay.
I've heard of that. Yeah.
That's very simple. Then you don't need it. But it is what is considered recommended for Americans or Europeans, not applicable. Now, ideal blood pressure 120/80, not 140/90. No change. Blood sugar less than 100, no change. Now, less than 200, this was made long time ago. The new data, but in the ASCBD risk calculator, they used 170. And I am recommending, because of the data, you need to lower to 140 or LDL 40 to 70. Yep. Now, amplifying this, optimal blood pressure is less than 120. 120 over 1 to 129 is elevated, and not medication, but more aggressive lifestyle and more dietary changes, more fruits, which has potassium and less sodium.
Mm-hmm.
Okay.
So that's how you should treat that, you're saying?
Initially at the earlier stage. But once it is more than 130, you need medication.
Yep. Okay, makes sense. How about any special considerations for South Asian women?
I must admire you for asking that question. This is so important. I already show you some data. Okay, and let me show that data again in case people have forgotten. South Asians account for 41% all female death from heart disease under the age of 50. And the South Asian women do not smoke. And at 50, they are premenopausal or perimenopausal. Yet, proportion is higher for women than men. Okay, and that proportion is, world average is 4%. Okay, now I'm going to show you some visual data. This is all from Institute of Health Metrics, who provides the corona data, COVID data every day. So their data, okay. Indian women, age 15 to 49, death, both sexes, is high and increasing.
Wow.
China, half the rate, but the trend is down. Only Fiji is in the screen. Everyone else is below the radar. You see that?
Yeah, that's so impressive.
So only 2 countries have this problem. Fiji is not it's a small island. So we have a major league problem. Now, if that's not bad enough, look at this now. This is women only. Okay. It's coming down. Look at this, females. It's coming down dramatically. And now look at the number of deaths between.
Yeah,
so
pretty dramatic.
Okay. And so this is dramatic. This has not received attention. That's why I told you that. I'm so glad you asked that. Now, let me explain to you why and what. It's not what you think. Or mostly. Okay. Compared to men, South Asian women have CAD rates are accelerating more rapidly than men. And if the trend continues, they will get parity by 2030. Certain risk factors like hypertension, abdominal obesity, diabetes, metabolic syndrome, etc., are high and increasing more rapidly. Okay, higher prevalence of then, so that is standard. Higher prevalence of depression. There's been a major factor, which is becoming a major risk factor. Poverty, major factor. Household air pollution. Who get the pollution from the solid fuel pollution in the room? Women. Higher prevalence of nearly two-thirds of South Asian women have low education, which is primary school or less education, which is associated with a 2-fold risk of CVD and 3-fold risk of death, published by Salim groups, just published, pure data. And low education accounts for 30% of all death among South Asians, and cardiovascular death is an important cause. Okay, let me show you one more slide. So this is for the states. Kerala, my state, has the most epidemiologically advanced states and high prevalence of risk factors. And look at the abdominal obesity. Men, 40%, women, 70%. But when you look at the BMI, you identify only less than 1/3. So we have problems. If you look just at the smoking, blood pressure, cholesterol, you missed. There are so many other important factors.
Yep, that is pretty impressive. Okay, so our next question would be, is there any other, so how is South Asian obesity different, and what is its role in heart disease?
Again, very important question. I have the answer. We touched upon this earlier in the life symbol 7. Waist size is 40 inches for man and for South Asian 35. Waist 102 and 90 is a big difference, big difference. Yep. And waist size for women 31, there's a big difference between men and women. For body mass index, there's no difference. And so this waist size is more important than BMI. Overweight, BMI more than 23, obesity more than 25, as opposed to, okay, BMI 25 is obese for Indians or South Asians. Now, I've been wondering about this for quite some time, why this lower waist circumference necessity. And most Caucasians and Blacks have a good reserve of subcutaneous fat. Like this. South Asians do not have subcutaneous depot. So it's only about 1/4 or 1/5 the size of the subcutaneous, which is the major sink for storing extra calories. And you can see it's called thin fat South Asian.
Yep.
Okay, there is no subcutaneous fat. okay, dysfunctional adipose tissue. And what happens? It get deposited in the liver. Everyone knows fatty liver. There's a fatty heart. There's fatty kidney. Fatty pancreas will lead to. So body mass index consists of both bone, muscle, and fat. But this measures, the waist circumference measure, it's a measure of the harmful visceral fat. And the danger of that one is from ectopic deposition in vital organs. So practical translation, a 5 feet tall South Asian woman, 118 means already overweight. 6 foot man, 169 overweight. Correspondingly, 119 is considered acceptable for a white, but for 5 feet, 128 becomes abnormal. So our BMI and waist is about 6 units lower to have an equal risk, metabolic risk. Now, I think this is even more this case illustrates even more. If we, okay, now this is taken from the what is called Delhi birth cohort. They have been following some 1,000 people. Now they are 31, 39. Okay, so they are not old. They are not even 40. So, and as when they become 50 and 60 and 70, the waistline, everything goes up. So these young adults, the obesity by traditional definition, only 20% men and 35% women. If you take the BMI 25, it doubles. BMI 23, 80% have BMI 23 and waist circumference if you use. So basically 70 to 80% of South Asians have abnormal fat depot and deposition or body composition.
That's so interesting. Wow. How about, are there any other testing that South Asians should be undergoing, including coronary calcium scoring?
Again, I must admire you. That is the test to be done. Okay, for those who are not familiar, this is a calcium score. There's no false positive. So this is a very specific measure of calcium in the coronary arteries. And latest data, the calcium score from 0 to 1,000, 1 to 100 to 100 to 300, 199, and this may be even more easy to read, 499,000. 1,000 calcium score increase the risk of sudden cardiac death fivefold. No smoking, no blood pressure, no nothing. Calcium,
and this is for all people, not just South Asians.
No, this is for South Asian. This is not for South Asian. South Asian, okay. Very studies. This is for all people. If all people, okay. This is maybe even more important for South Asians, but we don't have data. See, data on South Asians is very, very limited, as you know.
Yeah.
So calcium score tells you the risk of sudden death. Now, only there are so many prominent South Asians drop dead, especially movie actors and actors. And then we talk about for 1 or 2 days, okay, they could have done exercise more, this, that, do the angiogram, all nonsense. But this is one test done, and my hospitals, it's $50. But not covered by insurance. So, but I think usually it's recommended for people over the age of 40. Based on the data I presented, I would recommend doing this in both men and women by age 30, or at least in men doing a calcium score. And if
in
the
South Asians you're talking about.
South Asians, if the calcium score is more than 0, the disease has started, and I would start the patient on statin. Now,
so you're talking about, did you say, what age did you say again?
Usually, see, the reason for this, I have spent 30 years on this subject. So I have to micro-analyze each guideline, why they say what they say. So in the US, I told you that the death under the age of 50 is 2%. So, and So they recommend measuring the calcium score and the risk prediction whole cohort equation only after age 40. And we already showed you that the amount of death under the, so if you follow the pooled cohort equation or QRS3, you will have a substantial death. So I recommend at age 30, certainly for men, but women.
For South Asians, we're talking about.
South Asian men, okay?
Yep.
And, but it also case can be made for measuring South Asian women also. Okay, now the other thing is even more interesting. You tie up both the questions. Now, do you need 1000 calcium score to be concerned? No. If your calcium score 100 and your LP 50, your risk is increased 5-fold. You have none of the risk factors, but these two things, these are not in the standard guidelines. Okay, so you can identify, and in fact, last 25 years, I have been identifying this paper, measuring both. All my patients, I measure the calcium, the LPLA and calcium score. So I have been following somewhat similar algorithm myself. Now there is proof. Okay.
And what age should lipoprotein A be checked in South Asians, would you recommend? Or do you suggest?
That's a very good question. Let me put it in the background. All the guidelines, Europeans and Canadians guidelines recommend once in a lifetime measurement or lipoprotein little a, for the reason that it doesn't change because we have no medication.
Yeah.
But you identify this is almost like a BRCA gene. If your family history and BRCA gene, Angelina Jolie got the breast removed, okay, mastectomy. So like that, so LPLA is like a BRCA gene, okay, but BRCA gene, there is no treatment, LPLA treatment is coming. So LPLA measurement is recommended by all guidelines, but Canadian guidelines went one step further. They said, you measure LPLA once in a lifetime. That once in a lifetime has to be with the first time measure the lipids. So you do it once, and if the reliable lab, you never have to repeat unless and until the treatment is available and prescribed. So you measure, you identify the person. In fact, there is no other test. You provide this actually by the first test. There's a special name for clinically useful or something like that. It got a special category. If you have the cholesterol, but this has got a special category. I forgot the name. So LPLA. Now, LPLA is 90-95% genetically determined. And full expression of the gene happens by 2 by some studies and 5 by some studies. So you can measure as early as 5. As early as 5. And certainly,
age 5, you're saying?
Yes, 5 years of age. And certainly, if you have a family history of heart disease, I would measure it. Okay, measure the dad or mom. And this is also true for grandparents. Okay, the Australian study showed that they did a fantastic study, measured the LPLA in the newborn babies on the heel from a blotting paper, and the theory was to check the parents' CAD, but parents were too young to have MI. They skipped the parents, went to grandparents, and guess what? They found that every child newborn will have 4 grandparents. The number of grandparents and the age of MI correlated with the newborn baby's LPLA. So it's very powerful. So if you measure on children, and then you find high, you do what's called reverse cascade screening. So you check the parents and also for the first degree relatives.
So actually you're saying even family members, like children who should be checked as early as, or even adults should be checked as early as in their 20s or even in children.
Yeah, anytime after age, you can check lipoprotein little a.
After age 5, did you say?
Yes.
Okay, and it'll still be accurate.
Yes, now the next question comes up. If we find everything is high and no smoking, no blood pressure, no diabetes, what will you do with this information?
Yeah, right.
Okay, and that slide is here. Okay, this is a little complicated slide. Everybody, even newborn babies, have the mother has the high cholesterol. Newborn babies are born with fatty streaks. Okay, and so fatty streaks, everybody gets it, but the objective is to prevent it from unstable plaque. So keep the fatty that you cannot get rid of. That can be done, and that if you do nothing, okay, fatty streak, say you get a MI by age 70, but you can postpone that by giving statin at the age 30. You can modify it, and you reduce the risk by 60% and postpone the MI to 70. Now, okay, now if you do that, this is first thing first, because particularly in the US, statin is $5 for a month supply. So you can use that one, but then there is a residual risk from smoking, blood pressure, other risk factors. You can lower that one, so you can postpone, okay, event-free years to 80 by doing these things. But you cannot treat blood pressure if you don't have blood pressure. So you can see blood pressure and diabetes, you cannot bring it down too low, but it's not too low for LDL. Okay, so you can bring it down, and you cannot prevent death, but objective is, so remember I told you that our problem is not MI. Our problem is extremely premature MI.
Yeah.
And the only one thing you can do, you do this thing, and then the 30 goes hand in hand. You can easily use, and children as young as 10 we can use, but that's a different topic. Let me see.
Okay. Next question will be, what can South Asians do to help themselves after they've developed heart disease?
So I really appreciate your questions. Okay,
thank you so much.
This cover, your questions cover the entire gamut of questions the general public has it. Okay, now there are 3 things you should do. Life symbol I already talked about, 7 things. Okay, then they should take 4 secondary prevention medications. Aspirin, it's almost gone for primary prevention or people without heart disease. ACE inhibitors, beta blockers, and statin. 4 medication plus life symbol. But if they have heart disease, they need to take rosuvastatin 20 to 40 or atorvastatin 40 to 80. Don't mess around with the weak statin and homeopathic dose. Okay, now last 3 years I have been working on my book. Okay, I don't know whether you have seen this book. You said you
yeah, definitely have seen this book. Yeah.
Okay, and the 2nd edition, it's actually a totally new edition directed towards cardiologists, will be out next year. But all this information will be illustrated and explained.
Congratulations on that.
Sure, thank you. And more information currently available in my website.
Excellent.
Any other questions?
You know, I think I just wanted to perhaps have a picture of you enlarged so we can just show it for our audience without the slides, if that's possible.
Sure.
For both of us.
Okay. So take the share screen off.
Yeah, that's exactly what we're saying.
How do you take it off now? Okay, just. Okay, you ask. Stop sharing. Okay.
Okay, perfect. Excellent. Great. So, you know, I just wanted to conclude this session and just really thank you for all your time and your extensive knowledge and experience, and you know, taking the time out of your busy schedule for meeting with us. And I think hopefully this will help at least tens of thousands of people is what we're hoping, who are of South Asian origin, who will be listening.
Yeah, thank you. That's why I made special set of slides answering all the specific questions. So some of the slides may be available because not all of them are published. It's going to come into my book. If it goes into
Okay.
create a problem. Can I also have a copy of the recording? You can send me?
Oh, yeah, sure. Definitely.
Okay.
Yeah, we'll be glad to share that with
And
you.
enjoyed, and please let me know if I can be of further help in disseminating the information. I want
Yes.
this information to be out because, as you can see, that this is no longer much mystery.
Yeah.
Okay. So,
But it is unfortunately very much unknown to the vast
Yes.
majority of South Asians, which is sort of tragic.
And even 95% of the cardiologists.
Yep. Which is even more alarming. Yep.
Yes.
Well, thank you, sir, so much for your time and your passion for helping us as a people.
Did we take more than an hour?
Yeah, we did. It went by very quickly, but I really appreciate your energy and your stamina in doing this whole thing.
Thank you so much. Okay, stay in touch.
Thank you so much.
Thank you.
All right, well, great. I think we'll end this session.